Great. I'm honored to introduce Sara Meeks tonight, really a groundbreaker in the field of osteoporosis movement. She's been a physical therapist since 1962 when she graduated from Ithaca College with a BS cum laude. She received an MS in physical therapy in 1990, became a geriatric clinical specialist in 1994, and she's a certified Kripalu yoga instructor also in 1984. Her specialty is in the conservative management of people with osteoporosis, osteopenia, and spinal pathology. And it began in 1984, and it has resulted in an evidence-based, effective, comprehensive 12-point program called the Meeks Method, which has been trademarked by the US Patent Office. Sara has taught this and other subjects on osteoporosis movement and internationally. This program, designed to prevent, arrest, or reverse the patterns of postural change, is based on optimal anatomical alignment and emphasizes strengthening and lengthening of musculature, and will take people from frail to fit, and if that's where they want to go. Sara has been featured in many videos on her site and on the YouTube channel and on Bob and Brad, which are a duo of fellows that do a fabulous video, and they've interviewed her 3 times already. They're a fabulous PT team that has promoted her, and she's recently been on the Health Means videotaping from the Natural Approaches to Osteoporosis seminars. So we're thrilled to have you, Sara. Thank you for joining us.
Wow, thank you. And look at all the people that are here. Wow, that's really great. And you mentioned questions and answers and so on. I have a list of questions. Some people did send in questions. And I'd just like to say in the very beginning that if this particular presentation brings up more questions, I'm always open to emails primarily. Some people call me by phone, but I found that if I now that my name seems to be getting out more and I'm doing more things online than I was previously, but if I get on the phone with someone, I end up on the phone for about an hour. And so it kind of gets into my schedule a little bit. So I prefer to start out with emails or texts, something like that. And then we schedule a time where we can talk and really talk when I have the time to do that. So, and this is my favorite subject. Just a brief little bit of other history. I saw my first patient. I know some of you are professional medical people, and some of you are bookkeepers and probably teachers and lots of other kinds of work that you do. So in 1984, when I had already been a therapist for about 20 years, 22 years, I guess, I saw my first patient with known osteoporosis and a known acute compression fracture. I was working in a small hospital in my hometown of Alexandria Bay, New York, up on the St. Lawrence River on the border of Canada. And the doctor called me and he said, "Sara, you're the expert in this area. I'm going to turn the care of this patient over to you." Well, I almost fainted because I had never seen a patient with osteoporosis and certainly not one with an acute compression fracture. But I took up the challenge. I checked out her x-ray. I could see the compression fracture of the mid-thoracic spine. That's the area between your shoulder blades. And then I got out my trusty Gray's Anatomy book and looked at more of the anatomy. And I decided that if I had a compression fracture, then what I needed to do, if I need to get the load off from the fractured vertebra, I need to decompress the spine. So I had her lie on her back in the supine anatomical position. She was admitted to the hospital with a small pillow under her head and a little something under her knees for support. Then realizing that I had an active 65-year-old woman there who was a bookkeeper and a housekeeper, and she was carting her grandchildren around to various athletic events and so on, and doing exercise in the local gym, and just was an active individual. I needed to give her something to do. And so what you're going to experience here when I start to point them out is that I have they're all my original exercises, because I didn't have any research. I didn't have anything to follow. I just had to follow common sense and trying to keep the pressure off from the fractured site, and also strengthen the muscles around that and other parts of the body. It turned out it was very successful. She returned to her life that was happening before the fracture. And then I had an opportunity at 6 months to view her x-ray of the fracture site. And on the x-ray, I could clearly see that the vertebral body had grown back to its original height. Now, if you go to the doctor now and you have a compression fracture, they'll tell you that won't happen. But it did happen on my very first patient, because I kept giving her the exercises. She was in a brace so that she couldn't round or flex her spine. And she had a total a cure of that particular fracture. So as I was doing that, I started looking around my patient population and noticed that I was kind of favoring geriatric elderly people. And I all of a sudden was noticing that maybe with postural changes they were having, that a lot of them were having osteoporosis too. So that's when it began 37 years ago, and I'm still doing the same thing. So now, am I going to be able to share? Oh, yes, I'm going to share my screen. I'm going to give you a PowerPoint presentation, and I try to keep my language simple so everybody can understand it. So if I come up with a word that you don't understand, please understand you can always send me an email and ask me about it, or you can probably ask me here at the end of the presentation. Okay, so I guess I just press share screen. Yes, and here's the PowerPoint. And here is the first slide. I've already had it up here, and let me see here. I might need a little help here for some reason. I'm not finding. Oh, I know what. Okay, that's because that's there. All right, I got it. Slideshow.
There you go. And then
beginning. There's the beginning slide. Okay. So if you don't absolutely have to have this, a lot of you are probably already sitting in a chair. And if the chair has arms, well, it just has arms. If you have that one handy without, we're going to do a exercise called the perch posture. It's a little, maybe about the fourth slide into the presentation. And why are we here? Well, we want to get an introduction. This is an idea. This is definitely a small introduction into safe and therapeutic management of osteoporosis, natural management, no medications, and no surgeries. So I have a dream. I have a dream that someday anybody and everybody, if they have the condition of osteoporosis or other spinal pathology, they can go into therapy or exercise and be given a program that is number one, safe. There are some exercises that are contraindicated. There are some positions of the body that will create more fractures, and we're going to be taking a look at that. And we also want the program to be therapeutic and that it's skeletally appropriate for everyone. Now, just as a little addition to that, you should know that osteoporosis, everybody wonders where it comes from. Well, nobody really knows. It begins in the womb. It probably begins at conception. So if you think you have anything to do about it, don't blame yourself. I'm not going to say blame your parents, but it starts very early in the womb. Low birth weight in infants is related to fracture risk in later life. And it occurs in men, women, young people, old people, all colored people, every ethnicity you can imagine. Nobody is immune. Some people are more at risk than others, but don't spend a lot of time trying to figure out why you have it. You may never figure it out. What you need to figure out is what you're going to do about it, basically. that happened to me too, because I got diagnosed in the 60s. And as I got the report, I don't know if any of you have ever looked at or read the work of Elizabeth Kubler-Ross, but whenever anybody gets a diagnosis like osteoporosis or cancer or anything like that, a serious diagnosis, the first thing they do is go into denial. Oh no, not me, they got the wrong person. That's what exactly, I went through the same thing that everybody does, denial and frustration and anger. And then finally I came around to acceptance, and I figured, well, I've got to figure it out. I've already been working on this. And so now I really have to get even more busy because it's my problem also. So that's a little bit on that. All right. Okay, now my computer's going off. Okay. I am not here to teach you, okay? What I'm here to do is to invite you to take a journey with me to experience awareness of movement in your own body and to encourage you to live in the question. I constantly live in the question. Some people call me an expert, but I consider myself the perennial student. I'm always into the research literature. I'm always learning from my patients, from my colleagues, from the research literature, any place that I can. And mostly every day I learn something that I hadn't thought about in quite that way before. So I encourage you to do that. And paying attention to your own body, you know how important that is these days. You're probably reading about it in other presentations, is that, watching yourself as you move around and see how you move, how do you move? And what happens is, as you're going to see, and I'm going to talk about a little bit in the patterns of postural change, is we tend to do things in the same way, which means that as we get older, and that it's more difficult to do things in different ways in case we have an accident or an injury or sickness or something like that, where we have to change the way we do things. It can be difficult. So I began to change about, oh my goodness, almost 40 years ago, to do things in different ways, something different every day, so that I don't get so stuck in my patterns. Okay, so that's a little bit of that. So in the Meeks method, what's called alignment, 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 alignment is the key. The better body alignment that you have, you're going to have better muscle contraction and bones and weight-bearing forces, which are the two things that we want to strengthen our bones. Function follows form. You've probably heard the saying, form follows function in architecture and so on. I say function follows form. The better form you have, the better alignment you have, the better muscle contraction you're going to have where you need it, and the better weight-bearing forces you can do, and you can be functioning better with better form. And then it also provides more room for the internal organs. This is one of the things that happens. Now imagine your internal organs are somewhere between right about here on your neck and then down to your pubic area. And so if you're bending forward, they're being compressed. Now, if you're just bending forward for a moment and then you get out of that movement, okay, we probably all do that. But there are a lot of people that begin to lose body height and to develop postural correction, and they're always in that position, and that will affect the heart and the lungs and the digestion and every internal organ. So I like to think about moving, giving my internal organs more space. They all need it. So alignment. Okay, so the first thing I want you to think about is a plumb line. Now, you probably know what a plumb line is. It's basically that arrow is a plumb line. It's a straight line between 2 points. That's a plumb line. And carpenters use plumb lines, and other people that are building things plumb lines so they get things straight. So when we, in therapy, look at plumb lines, we look at the side of the body, front of the body, back of the body, but this is called an internal plumb line. Now, this plumb line begins, in this case, that's actually me. I was the model for this little picture here, in a perch posture. So if we're all sitting in a chair, you notice how I'm sitting out on the edge of the chair. So I encourage you to come to the edge of your chair, or even sit on the corner of your chair if you like, because if you sit on the corner of your chair or your stool, you will be sitting directly on the base of the pelvis, which is located right underneath the spine and will help you elongate your spine. Notice that my knees are well below my waistline or my hips. And that is because research has shown us that if we open up, now this is hip opening. In yoga, they usually have, and you heard I'm a yoga instructor, have been for many years. I've been practicing and teaching yoga since 1977. That's quite a long time also. That they, generally speaking, will have the legs move out into external rotation. And that can be a real problem too, because as we get older, we lose internal rotation of the hips. And we want to keep all the motion that we can. Now, this to me is the hip opener. It's called hip extension slightly. If I bend the hip more, it's called hip flexion. And research has shown that opening up the hips to about 120, let's see if I can, whoops, degrees relieves compression on the spine. Sitting is the position of most compression on the spine. And the most common injury in osteoporosis is a compression fracture. Usually not where the DEXA scan is done in the lower back, but usually in the upper back, between the shoulder blades, the thoracic spine. That's the area that's most commonly fractured. Now, when I use the word fracture, I know some people don't understand that that means that's a broken bone. So you've essentially broken a bone when you have a compression fracture. So I like to sit a little high. The higher you sit, okay, then the less compression you're going to have. One of my mottos is sit less, stand more, and when you can't do that, lie down on your back and do the realignment routine that you're going to receive as a result of taking this webinar. And also, if you don't get it, or if you want to pass something on to a friend, they can always contact me and I'll send them a copy of that. So that is called the perch posture. I'm not sitting back in the chair. When you sit back in the chair, most of the time you're going to bend your spine, and that's not a good way to do whether or not you have osteoporosis, because it's supposed to have an arch, and we're going to look at a picture like that. Now, to get out of the chair, what we do is something called a hip hinge. Notice I have my hands right in the hip crease, right where this is where my hip joint is. So I don't always do that now, but this is how I teach it, and this is what I started with. I put my hands right there, and I lean forward at that point. So try it. Put your hands right in that hip hinge, and continue to have that internal plumb line going up through your back, all the way up to the top of your head. And so you learn to hinge at the hip. And then what you do is you press your feet into the floor, whoops, and you come into a standing posture, all right? And again, envisioning the internal plumb line that originates between your feet, runs straight up between your legs, through the base of the pelvis, the pubic bone, and the tailbone, up through the central core of your body, and out through the crown of your head. Now, the crown of your head is also called the fontanelle. Some of you may know where the fontanelle is. It's where the soft spot you had as a baby. So it's on the top of your head, but not in the front, not in the back, but sort of toward the back on the top of the head. So just put your hand right up there and feel where the fontanelle was, okay? That's at the crown of the head. So you can stand if you want to, and I'm going to take you through an exercise called the foot press fontanelle feather, okay? You can also do this while you're sitting if you don't want to stand up. You can get a sense of this when you're sitting. So if you're standing, what you want to do is bring your feet all between 4 and 6 inches apart. So you don't want to have a really wide base, and you don't want your feet touching each other. Okay, you want about 4 to 6 inches between your feet, with your toes facing forward, not turned out to the side, either in or out. Okay, just facing as much forward as you can. And then what you do is keep your feet on the floor and shift your weight back to your heels. So you don't lift your toes or anything, you just shift your weight back onto your heels. And then you run the weight up along the outer border of your foot. That's the 5th metatarsal that goes up to your little toe. And then you bring your weight across the ball of the foot. Now, the most important part of this is the weight on the sides of the feet, because it will create an arch, a medial arch in your foot, and you should have an arch there. Now, take your hand, pretend it's like a feather, and place it right on the fontanelle, okay? Take a breath in, press your feet into the floor through that foot triangle support, and then press your head up into your hand as if you were going to push that feather of your hand right off the top of your head. And then relax. Take another breath, press your feet, and then press the feather off the top of your head. And see if you can scan your body and feel anything happening. Now, I'm seated on a stool right now, and I can feel the lengthening of my body all the way from where I'm sitting and all the way up through my head. Now, all of you might not feel that the first time, but give it a try. Look in the mirror. If you have a full-length mirror at home, it's a good idea to look in the mirror, because sometimes you can't feel in your body, but if you're looking in the mirror, you can see what's happening. It's very helpful. Okay, so what is the Meeks method? Well, it is a comprehensive 12-point movement and exercise program that I developed around patients diagnosed with osteoporosis or osteopenia. Now, osteoporosis and osteopenia are essentially the same thing. They are bone loss. You're losing bone. It's with osteoporosis, you've lost more than you have with osteopenia. However, you can still have compression fractures with osteopenia and even with normal bone, because it doesn't always depend upon the quantity of bone you have, but more the quality of bone. So we're going to look into that. It's shown to be clinically successful also for scoliosis, spinal stenosis, which is a narrowing of the of the spinal tract all the way down, and that you get pressure on the nerves, and you can get actually paralysis in your lower legs, all kinds of things, and it's very painful. And a lot of people bend forward because it feels better to bend forward. So I've seen patients that have all of this. They have osteoporosis, scoliosis, spinal stenosis, spondylolisthesis, and other pathologies also, and comorbidities such as COPD or lung issues, heart issues. They've had joint replacements, and just about anything that shows up in a physical therapy clinic. So that's why I focus on alignment, because it will help all of this and more. Body alignment is the key to me. The primary objective is safety in movement and minimization of risk for fracture. I used to say prevention of fracture, but I can't always prevent it because I don't know what people are doing in their lives all the time. So I want to minimize their risk. And it's based on principles of anatomical alignment, kinesiology, which is the movement of anatomical movement, and biomechanics. Basically what I learned in physical therapy school, that's all it is. This is what I call the Meeks Method wheel, and you will notice that there are a lot of points to it. You see, a lot of people have exercise for osteoporosis, but I have what's called a comprehensive approach. I usually start with assessment or pre-assessment. Actually, those of you who have done consults with me, I do a pre-assessment. I get some information early on. I want to educate my patients as to what's going on and what we're going to be doing and take them to good sources of information. There's a lot of information on the internet that is not adequate for osteoporosis. Some of it is very dangerous and can cause fractures. So back in physical therapy school, and then in my first job, I had the opportunity to be trained under two physicians who were the inventors of physiatry or exercise and movement for people with disabilities, rehabilitation medicine. And Arthur Aberson, he was my instructor in college. He said, you know, when you look in the research or when you get any information from anywhere, always consider your source. And I have never forgotten that. That was when I was a senior in college, and I took a course with him. In my first job after I graduated, I worked at the Rusk Institute in New York City and in Manhattan. And the leader there was Dr. Rusk himself. And every Friday we had team meetings, and he was there for most of those meetings. So I learned from the best way back then. And I've never forgotten some of their words of wisdom. And I just keep saying that, consider my source. I look at something on the internet and I'm saying, you know, who is this person that's saying this? So I'll look them up. And usually you can find information on who's written the article. And if that's something that you want to, you know, find out more about, that's fine. But just understand that there are a lot of people out there that are teaching things for osteoporosis, and they really are not really trained or skilled enough to be able to do that. So consider your source. So now I don't always use everything on this wheel for everybody. Of course, I have to do the assessment. And then I teach site-specific exercises, body mechanics, very important, postural correction, we've already done one, working with balance, because with better balance, people will be less likely to fall. And if they fall, they may break a bone, they may not, depending upon the quality of the bone. Weight-bearing exercise, so what is that? Weight-bearing exercise means bearing your body weight through your bones. It does not mean going into the gym and lifting a weight. That is not weight bearing, that is weight lifting or weight training. So if you want to do weight bearing, if you're on your hands and knees, you're bearing weight on your arms and your legs. If you're standing, you're bearing weight up through your feet. If you're sitting, your weight is starting down in your buttock area, and so on. So that's what weight bearing is. Modalities, including heat and ice and different things like that. Bracing, I'm going to be talking about a special brace called the Spinal Med, which has been designed just for osteoporosis and compression fracture. Breathing exercises, big part of my program. Also relaxation, that's the first thing I have people do, is lie on their back and say, now just relax and let gravity do the work. Just let your body not melt into the table and not collapse, but just relax. And then slow down your breath and focus on the breath. Now your mind will travel, but you come back to that breath and it'll bring you right into the moment. So getting some relaxation. Advanced exercise means going into a yoga class, a Pilates class, into the gym or something like that, and there are a lot of guidelines for that. So it's a pretty comprehensive approach to this condition. These are the patterns of postural change, or my idea of what happens to the human body as, but not necessarily because, we age. Now, if you look at this picture, think to yourself, if you thought of somebody who was 25 years old, which guy would that be? If you think of somebody who's 85 or 90 years old, which guy would that be? Do we not associate the aging process with this kind of posturing, this forward flexion? Well, I'll tell you, I have seen people in their 90s who look like the guy on the left and people in their 20s that look like the guy on the right. So it is not age. A lot of it is depending if we're born into a fairly excuse me, I'm going to put this in quotes, normal human body, that we will grow up and look more like the guy on the left. All right. But then we live our lives. How much do we sit? How much do we stand? What kind of work do we do? What kind of accidents have we been in? What kind of illnesses have we been? They all affect our body. So my idea is to, whoops, okay, wrong thing here, prevent, arrest, or reverse the patterns of postural change. Remember, function follows form. The guy on the left is going to be able to breathe better than the guy on the right. He's also going to be better able to digest his food. Okay, and his heart will be working better, and so on. That's how it happens. I can give more details for anybody who would like it. Okay, so here we are, back to alignment. All right. Some of you are very familiar with this. On the left is the front of the backbone. Those are your vertebral bodies. That's where the fractures occur. On the far right is the back of the backbone. Those are your spinous processes going right straight up and or down, whichever way you want to look at it. And that big bone at the bottom is called the sacrum. But in the middle is the one that I want you to take a look at. This is what I go by, the curves in the spine. This is the side view of the spine. So we have down at the bottom, we have the tailbone or the coccyx, which is curled under. See here? And then that goes up to the sacrum. And now notice the curve here. And then this is where the DEXA scan does. This is your lumbar spine down here. And you have a curve in the other direction. And then you come up to the thoracic area. And this is called the kyphosis. And then another curve up in your neck. And this is what gives the spine its flexibility, or at least one of the things that gives the spine its flexibility. And no matter what I am teaching in exercise, I'm always being conscious that I want to keep these curves in the spine. So I do not teach pelvic tilts, because in pelvic tilts, you tend to move the spine too in the wrong direction. Okay. And I don't teach flattening the lower back. And I know in some exercise regimes, they do that. I want to have the curve in the lower back. Likewise with the neck, I don't flatten out the neck. This is optimal anatomical alignment is the curves in the spine. So I like to teach everything I do with the curves in the spine. Okay, so here we are with a side view of the spine. This is called what I call the front of the backbone. These are the vertebral bodies out here. And the most fractures occur, this is the thoracic vertebra number 6. There's 12 thoracic vertebrae. And at that level and below is where most compression fractures occur. The DEXA scan is done in the lower back, in the lumbar spine. And the reason it's done down there is because it stands alone. And up here, of course, we have the rib cage and the sternum, and we have other bones. So we can't do the test up here. But this is where most things happen, right up here in the thoracic. The patient I told you about, she had a fracture of T8, which would be 2 down from 6, of course. So now we have a treatment dilemma here in therapy. Muscle contraction and weight-bearing forces are the main things we want to get on our bone, forces that we want to get on our bones to create stronger bones. In this area of the body, there are no muscle attachments on the front of the backbone, okay? There are, let's see if I can find my mouse here now. Let's see where I go. Okay. There are muscles on the back, on the spinous processes in the back that go all the way up the back, following the curves all the way up to the base of the skull. But there are no muscles in this area. So how do we lengthen? How do we create more force on the bones in this area? This to me is where alignment comes in, because this is the optimal alignment of the spine with the curves. So if I can keep these curves, then I have more of a chance of really treating that area of the body. Now, some of you probably take yoga, maybe even some of you teach yoga, I don't know. But one of the common things that they ask for in yoga classes is to tuck the tailbone. I can tell you, don't tuck the tailbone, it's already tucked. And also, because you can see it curls under. And when people do that, then they start to flex more and move the lower back also, and putting strain on the lower back. So just forget about tucking the tailbone. It's not necessary. Just leave it where it is, and it probably will be fine unless somebody's had some kind of an accident where they fractured the bone or something like that. Remembering we want to keep the curves of the spine as much as possible. This is the second area of concern. You can break any bone in the body, but these are the two that are more life-threatening: the spinal fractures and also the hip fractures. These fractures occur in what is called the neck of the femur bone. I had one patient kind of mixed up the neck behind here and the one in her hip. I said, no, they're talking about the one in your hip, not the one that holds your head up. So we've got to settle that. But that's where most of these fractures occur, right in the femoral neck, or in the what's called the intertrochanteric area. This big bumpy bone out to the side is called the greater trochanter. Right here, this is the greater trochanter. So I also want you to notice the alignment of this bone. This is the femur bone down below. It comes right up from your foot, right through the knee, and so on. And then your hip makes a curve and goes into this socket. This is probably the most stable joint in your body, because you have a big ball of a femoral head there that fits right in the socket. And then you can bring the leg forward and backward and sideward both ways, and circles and out to the side and back and across the other leg and so on. So it is the most flexible also, but also the most stable joint in your body. The least stable joint I always classify as the knee, because in the knee you just have one bone seated on top of the other, held together with some ligaments and other muscles and so on. So it's not as stable as the hip. We have a treatment dilemma here because, again, there are no muscle attachments in the area of the hip that tends to fracture. So this is, again, why alignment is so important. Okay, so here we come to something I kind of debated whether to tell you this, but I'd like to name the bones that are the most useful in osteoporosis management. The first one is well, I don't have it labeled here, but are the clavicles. Okay, here, I guess they are the wings of the collarbones, at the collarbones. So if you put your hand right in the middle of your chest, right there, you'll find a little indentation. And if you press your thumb down, that muscle I call the M bone, and I'll give you its real name in just a couple of minutes, but that's right in the middle between your collarbones. So I'd like you to just take one hand and trace your collarbones out to the side. You can do it this way, however you want. Notice the collarbones don't go straight out usually. If yours go straight out, fine. But most of the time I found they kind of go up a little bit. So you know right where your collarbones are. All right. Now take a breath. As you breathe out, spread the wings of your collarbones. See if you can feel like you're going to stretch those collarbones out to the side. One of my colleagues says what she does is imagine that your collarbones are like arrows and you shoot the arrows out the side. So whether you like the arrow or the wings, I learned the wings in a yoga class. I thought it was when a yoga teacher, I was in a class up at Kripalu, said, no, you've got your feet in place, everything's in place. Now spread the wings of your collarbone. And it felt so good to stretch out my chest, because these muscles, imagine that hunched over guy, all these muscles in here are getting tight too. Then you have your breastbone. Now your breastbone's actually 3 bones. The top one I call the M bone. That's called the manubrium. The middle one is the sternum. That's right in your chest, right between the breasts. And then you have the X bone down here, the xiphoid process. Okay, so there are 3 bones in the chest there. And you notice the rib attachments. The R bones are your lower ribs. So you can feel your lower ribs. And now you see the pelvis there, the top of the pelvis. It's between the R bones and the H bone. So place your hands on the top of your pelvis. You should have a space where you can kind of put your hands between the lower ribs and the top of your pelvis. If you can't do this, if you have, I think that you should have at least 3 inches of space here. And if you don't, it means probably you're getting compression in your spine and your ribs are descending down towards your pelvis. I've actually seen patients where the ribs are inside the pelvis. The H bones are on the front of the pelvis. So if you feel your lower ribs and you just kind of go straight down, you'll find a little bumpy bone on the front of your pelvis. I call them the headlights of the pelvis. And I like to keep these in alignment when I'm doing various yoga postures or exercises. The T-bone is the tailbone, the rocker bottom of the pelvis. Those are the ischial bones and the pubic bones that connect actually it's the rocker bottom connects the pubic bone with the tailbone, and then you have the pubic bone right in the front. You probably all know where that is, and then the sits bones are the big bones there on the it's called the ischium or the ischial tuberosity, called the sits bones. Now, the thing in yoga, this is another thing a lot of teachers do. They have people sit on the sits bones. So are you still sitting? If you're sitting, feel where you have your body weight. Now tilt forward a little bit on your pubic bone, put your hand behind your back and feel what happens to your back. And then bring your weight back onto the sits bones and feel what happens. Now what happens for me, if I tilt the pelvis forward, I get more of an arch in my back. And if I tilt back onto the sits bones, the back rounds. So I prefer teaching people to sit with the weight more forward on the pubic bone so that I maintain the arch in my lower back. Remember, the lower back is supposed to be arched, okay? And sitting on the sits bones makes it round. And I kind of discovered this by accident. I was seated on the floor in a yoga class, again at Kripalu. And somebody had me sit on the sits bones and then lengthen your back. And all of a sudden I realized I can't do that. And then I tilted forward and I can really lengthen up. So that's where I started that kind of an idea. So if anybody's interested, I've actually developed a pillow. It's called an easy posture pillow. If you want to send me for some information on that, I'd be happy to send it to you. And it basically is designed to cradle the bottom of your pelvis, which is right underneath your spine, and it helps support the spine. Okay, there we go. Again, the hip joint with no muscle attachments. A few basic principles of the Meeks method. I know it says focus on physics, so everybody's going to go, oh my God, not physics. Okay, anyway, it's not too bad. Newton's third law, for every action, there's an equal and opposite reaction. Now, you may have noticed when we did the standing, when we did the foot press and the fontanelle, that as you pushed your feet down, your body went up slightly. Okay, depends upon the strength of your muscles, but this is what happens when you can do it in any posture, pretty much in yoga. That can really help you in stability in yoga. But that's one of the principles that I follow. The force of gravity, it's a big force. We get used to it, so we don't even notice it. However, you can do exercise in assisted gravity. Now, that would be an exercise like if I have my arm up in the air, and then I bring it down like in a lat pull down. Maybe some of you do that in the gym, a lat pull down, you pull it. That's gravity assisted. So it makes it easy, right? So then you could have a neutral gravity, depending upon where your body is positioned. Or you can work against gravity. Now, against gravity is a lot harder than assisted gravity. Reciprocal inhibition. If I want to, let's say, let me back up a little bit, change this so maybe you can see me a little bit better. If I want to do a biceps curl, you could try this. Just bend your elbow. The triceps, which is on the other side, has to relax so I can contract the biceps. If I want to work the triceps, the biceps has to relax so I can straighten the arm, the elbow. So you have the what we call the prime mover in a biceps curl would be the biceps. And then you have the antagonist or the opposite muscle, which is the triceps. And this is true all throughout the body. You have the prime movers, and then you have the antagonists, then you have other synergistic muscles. There are a few muscles that work all by themselves. They all have some kind of a buddy there, like to help them along or to relax so that they can use the muscle and so on. Muscle contraction, weight-bearing forces are necessary for healthy bones. We've already said that. Compression is the main force on our bones because of the force of gravity. And then if you're sitting, then you have the force of your body on the chair and an equal and opposite force coming up into your sits bones. And then you have the force of gravity coming down. This is why sitting is the position of most compression. You also have tensile or lengthening forces, where you lengthen out, and that's, I guess, commonly known as stretching. And then shear. Now, shear is sliding and gliding forces that our bones are rubbing on each other or we're twisting in some way like that. And that is where the bones are the weakest in shear force, twisting, and so on. And they all act on our bones, and they're necessary for bone growth and bone health. Healthy bones are strongest in compression, next in tensile or lengthening, and weakest in shear. Now, truth be told, in the spine, there is no motion that you can do in isolation. For example, if you flex the spine, if you come forward, you may also be rotating a little bit, or you may be getting some shear force on some of those vertebrae. There's no isolated movement in the spine itself. Now, according to a research article in 2009 by Nykander, he found that random and high velocity forces build denser and stronger bones. It was a research article done on, or test done on elite athletes, young athletes. And they found that the high jumpers and triple jumpers had the best force, and the people are the best bones, and the people with the weakest bones were swimmers. So you need to have certain forces on your bones in order to gain stronger bones. So how often do you get these kinds of force on your bones? And can it be done? How do you get these kinds of forces on your patients or your own bones? Okay, well, one way that I try to do things, like if I'm going for a walk, or when I used to be a runner, then I would walk backward or run backward, go sideward, go on uneven surfaces, like go on a trail, walk on the grass, get different forces on your bones. Your bones will react to random, not necessarily always high velocity. You're not going to get people who are going to be able to do that right away. But here's a little idea. It's called bump, bump. So if you want to stand up and do this, you stand up, then you lift your heels. You come up on the balls of your feet, not on your toes, but come up on the balls of your feet. I'm going to stand up. You won't be able to see my whole body, but you'll probably see it move. So I'm going to lift up my heels, and then I drop my heels, and I go bump, 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 bump. You can do one foot, bump, bump, and then the other one, or both together. And the idea is that this is an exercise that you can fit into your daily routine, anywhere, anytime you want. And it just gives a random force onto your bones. Now, look, if you're working with patients and you've had somebody that's just had an acute compression fracture, don't give them bump bump. Wait till they heal from that fracture before you do anything like that. But let's say that you have osteoporosis and you haven't had any compression. Now, here's another thing that you want to think about. I didn't put it in a slide. Compression fractures in the back, up to 80% of them are silent, which means you would never know it. And that is just an amazing thing for me. We see in therapy about 30% of what's really happening out there. So I've had I remember one patient, I had more patients, but this one had lost 8 inches of body height. Never had a day of back pain in her life that she could remember. Those are silent fractures. I had one lady had lost 10 inches of body height and had no idea. She never had back pain. She just got shorter. There are a lot of people like that. So here's a word to the wise. To all of you on this webinar, keep track of your body height. Because if you don't, I can tell you from my own personal experience that there are physicians out there that think that it never changes. It can change, and it can change radically. And you're going to have to be proactive that when you go to the doctor and they want to weigh you, they always want to weigh you, don't they? Yeah. Make sure they measure your body height too. You'll figure out a way to keep track. If you've lost 2 to 2.5 inches of body height, the chances are very good that you have the beginning, at least, of a compression fracture in your back, because most of the body height is lost in the back. Any questions on that? I am only too happy to talk about it because it is really scary. Okay, so how do I determine my intervention to my patients? Well, first thing I do is look at the clinical condition of the patient. I see people of all ages, all kinds of conditions, some very serious, some less so, some with accidents, some with illnesses, just lots and lots of things. So I have to always bear in mind, who is this person and what is the condition and what can I do? The cardinal signs of fracture of minimal trauma, what's that? Any fall from a standing body height that results in a fracture, that fracture is a fracture of minimal trauma. I don't care if you fall on the ice, the concrete, the grass, the tile floor, whatever it is, you should be able to catch yourself with your hand, and the bones of your hands and arms should be able to take that force. And if they don't, that's a fracture of minimal trauma. Is one of the first signs of osteoporosis. Hyperkyphosis of the thoracic spine. We should have a kyphosis. We have a curve in the thoracic spine that helps to protect the heart and lungs. A hyperkyphosis, I believe, is any kyphosis curve over 40 degrees, but it might be 30 degrees. I'm not sure. I'll have to check on that. But we should have a natural curve in that upper back. And then, of course, the loss of body height that I just talked about, because that is one of the cardinal, these are the cardinal first signs. Then I have to consider comorbidities. I picked these two as being the most dangerous and so on. COPD, chronic, this is emphysema, okay? Chronic obstructive, I forget all I also always say COPD, and fear. Fear can keep us from doing what we need to do when we're diagnosed with osteoporosis. So we need to work on that. And I see a lot of patients who are very fearful, but they tend to be fearful. Sometimes I see people in their 40s and 50s, and they're dreadfully fearful of what they're going to be like when they're 70. I say, well, let's get into the present moment. What are you doing now? Let's start here and see how we can take every day as it comes. And that's kind of the way I look at things. I've done that for a long, long time. But fear can keep us from really taking care of ourselves too. Patient preferences, what do they want to do? I have my agenda. They probably have their agenda. So I try to get, working together with that person. So where am I meeting this patient? I see patients in the ICU, in the hospital. I see patients in outpatients, home care, just about any place you can imagine. And I have to take that into consideration. And the tests that I look for are the DEXA, TBS, that's a trabecular bone score, that has to do with the architecture of your bone. A lateral vertebral assessment is a side view of your entire spine from all the way down in the lumbar spine all the way up to about T4. So you can see the curves and you can see if there's any compression. And then, of course, an X-ray would be the diagnostic tool for a fracture. Okay, so these are the three cardinal signs. So if you've had a Colles fracture on your wrist, that's a first sign. If you've had a fracture of your metatarsal, one of the long bones in your foot, that's a fracture of minimal trauma. Okay, I had a friend of mine had a spiral fracture of her tibia bone, the main bone in the lower leg, and she ran a marathon on it. She had some kind of a brace on her leg, but you know, that's a fracture of minimal trauma. So those are first signs. In my practice, for those of you who are physical therapists possibly out there, this is how I do it. First, I call it isolate. What that means is I determine areas of restriction and weakness in the body. Where are the strong muscles? Where are they restricted? And then as I do the program, I work on relieving restriction or tightness in certain muscles and strengthening where they're weak, and then integrate that into functional movement. That's kind of just a little view of how I work with patients. Okay, so what is this condition anyway? Osteoporosis or osteopenia. According to the NIH Consensus Development Panel, this is a long time ago, but I've never found a better definition. It's a musculoskeletal disorder. It's not a disease. People call it a disease, but it's really technically not a disease. It's a disorder with compromised bone strength that predisposes an individual to an increased fracture risk. And again, what is a fracture? It's a broken bone. And what is bone strength? Bone density plus bone quality make up what is called bone strength. And this is just, I've written down there, architecture, mineralization, and microdamage accumulation within the bone affects the quality. So I'm going to show you, this is a DEXA scan. This is what it looks like in case there's somebody that's never had one. This is one in the lower back, over on the left, and then on the hip. They usually do the left hip. They ask you, you know, if you're right-handed, you get the left hip, and I think if you're left-handed, you get the right hip. I don't know. And so people think, well, I just have it in my lower back and my hip. I said, no, that's just where they test. You can have it anywhere. Okay, so now we're going to get to some of the elements of bone strength. This is brand new. Somebody on one of their let's see, Leslie, I think this is, about what new have I learned recently? Well, I've learned this in the last 2 months. Let me put it that way. I came across an article, and I'm going to give you the reference at the end of what I'm talking about here, or what are the elements of bone strength and quality? Bone quality has been linked to fracture risk, poor bone quality. Bone density, or the DEXA scan, has not been linked to fracture risk. I know people call me and say that's what the physician has told them, but it's not really. It's one of 9 elements that can be related to fracture risk. So your bone mineral density, or your DEXA scan, is a measurement of the quantity of bone in a given area. And it's the quantity only, and this is insufficient as a measure of quality, as bone strength is dependent on a large variety of interconnected factors. It's not simple. Bone mineralization degree. This is mainly responsible for the ability to resist deformation of the bone or the stiffness of the bone. You need to have good mineralization of bone. And this is part of the mineralization. It's called hydroxyapatite, the crystal size and heterogeneity of hydroxyapatite. Now, this is one of the elements that I know less about than the other ones. But I did read in this article that it plays a big role in bone mineralization. Collagen. Who hasn't heard of collagen these days? Everything's collagen. Collagen supplements, collagen this, collagen that. Collagen is actually the most prevalent protein in your body, but it allows for energy absorption or toughness, which is different than the mineralization. So I was talking today with Shelley, and we're talking about the bone is like a piece of concrete and then a piece of rubber. So the bone mineralization would be the concrete, the collagen would be the piece of rubber, because it allows our bones to absorb the energy that's coming in from a force. It's part of bone quality. Osteocyte. The osteocytes are the most abundant cells in bone. And let's see, I can't see this here. And I think that they are very important in bone remodeling and mineral homeostasis. Bone remodeling, and some of you have not heard of that, but you have in your body other cells called osteoblasts. Those are the cells that build bone. And then there's osteoclasts. Those are the cells that come in and get rid of all the old bone. So you have the osteoclasts who break down bone and the osteoblasts that build bone. However, also involved in this process, and this is one of the most important processes in your body for bone health, is the bone remodeling. And what happens with most of the medications, and this is all I'll say on medication, if you're thinking of taking a medication, be sure you do your research and look at the possible benefits and also the risks. But most of the medicines interfere some way with a natural remodeling process. Either they cut down the action of the osteoclast or they increase the action of the osteoblasts, but it's a change in the natural bone remodeling process. I don't know how that can change, but I just wanted to mention that about the medication. So be sure you do your research if you decide to take medications, because not all the medications are the same. Trabecular, that's the inner structure of your bone, and cortical, that's the outer structure. Microarchitecture shows that exercise will improve both of these, thereby improving bone strength. And they mention this in the article quite a lot, that exercise is really very important. Whole body geometry, that's the size, shape, cortical thickness, and cross-sectional area of all the bones, and they are related to bone strength and fracture occurrence. So the bones in your spine, they're the smallest in your neck and the largest down by the sacrum, the lumbar spine. And as it turns out, the neck bones are more dense than the lower bones are, even though the lower bones are bigger. And most of us, we're not exactly sure why that is, but most of us think that's because, maybe you've watched me. I'm watching myself in the picture here, and sometimes I have my head this way or up or down or like that, or we're always moving our head all day long, and that's putting stress on the bones in the neck, and that makes the bones stronger and more dense by the amount of area, because the density of the bone is how much bone there is in a given area. Okay, so here's the reference. It was published in 2013. That sounds like a really ancient date, but I just discovered this about a month ago, and it's the first thing that I've been able to find that really goes through all of the different elements that contribute to bone quality and bone strength. So I think that Shelley has this. I sent her a copy of this research article. And Shelley's going to send it out. And if you happen not to get it, make sure you contact her or me. I'll send you a copy. I know right where it is on my computer. It's one that I'm working with. It's not a difficult read, but it's a little complicated there because a lot of these elements that I've showed you, they interact with each other. but at last I have a little bit more to look at than just bone density, and then also that the bone quality, the architecture of the bone that I had before. The first principle of my method is to unload the vertebral bodies. Now, I know that in a lot of places they'll think, well, if you have osteoporosis, you have to load the bone. And we know that we have to load the bone. I'm not disagreeing with that. We load the bone to have the bone grow and get stronger. On the other hand, when I deal with physically frail people who already had fractures, I'm not going to start to load the bones. The first thing I want to do is unload them. This is a model of the spine in the decompression position, which is the first position that I put my first patient in, and I still do the same thing. For every action, there's an equal and opposite. As you lie on the floor, you lie on your bed, you lie on whatever you lie on, including this foam roller here that the skeleton is on, you get an equal and opposite force of the weight of your body, which will help to lengthen out the front of the backbone. So you get the tensile force as a result of lying on your back this way. And this is, to me, this is the single best exercise for most back pain. Lie on your back. There's a realignment routine that also Shelley has, I sent to her. And the first exercise is called the decompression exercise, where you lie on your back, you bend your hips and your knees, put your weight on your feet, and you put your arms out to the sides, like with your palms up, so that you're kind of stretching out your chest a little bit, and you just lie there and breathe. That's all you do for starters. And then there are exercises to strengthen some of the muscles as you go along. This is one of the exercises called decompression. You can either lie there with your feet on the floor, or you can also imagine yourself putting your feet up on the sofa, something like that. And the whole idea of this decompression is to isolate your back. You just lie on your back and let your back relax. You know, it's very hard to do nothing. The shoulder press. So you imagine that underneath your shoulder, right there, that's called the acromion process of the scapula, the shoulder blade. And you imagine that you have a sponge there that's filled with water, and you press your shoulders down, squeeze the water out of the sponges. There's much more detail in the realignment routine text. The head press. This is a little bit difficult because some people, when they lie on their back, what happens if they have a big hyperkyphosis, they'll tilt their head way back to get their head on the table. Or if they have some other condition, they may tuck their chin down toward their chest. So if they lift their head back, then I have them bring the chin down and then press the head into the floor or into the table. If they're bent down, I will have them pick the chin up and do it. And sometimes I'll put like a rolled up small hand towel or a smaller towel than that. One of my patients, I think she used a washcloth under her neck, just to give her neck a little bit of support for this exercise. Leg lengthener, you lie on your back, you straighten one leg down, press out through your heel. Don't try to bring your toes up, just press your heel out, and then you lengthen the leg all the way from the top of the pelvis down to the back, down to the foot here. Now, if you have pain or discomfort with the leg lengthener, you should start with the leg press. Eventually, you'll do both of those exercises, but the leg press will strengthen the muscles in the back, the gluteus maximus, the quadriceps on the front of your thigh, and also your lower back extensors. And here comes one of my favorite exercises. It's called the side lying leg lift. Maybe some of you have heard of the gluteus medius muscle. This is a muscle on the side of your hip. And when you walk, if you put your right foot forward, your left gluteus medius has to stabilize the left hip so you can do that, whether you put the foot forward or backward. And there are a lot of exercises out on the internet that they say strengthen the gluteus medius. So I decided to dive deep into the research literature. And I found an article where they looked at I think it was 6 different exercises to strengthen the gluteus medius. And this one was number 1. And this is the one I advocate for everybody. It's called the side lying leg lift. So you lie on your side. That's my husband, John, there. He was the model for that, doing the side lying leg lift. And then what you do is you press, I think that's the next thing right here. You press your bottom leg down into the surface that you're lying on, whether it's the floor or your bed, or wherever you're lying on a treatment table or something like that. And as you press that leg down, you will feel that the other one will start to lift. Remember, for every action, there's an equal and opposite. So, and then of course you can build on that as you lift that upper leg up there, because that's still keep pressing on the lower leg. And then you want to have your foot positioned so that if your foot was able to touch the ceiling, your heel would touch first. Now here you see in this picture, he's kind of got his toes up a little more than his heel, but we don't want to be rotating the leg outward to do this exercise. We want to keep the side of the foot going up toward the ceiling. You'll hold the lift 10 to 20 seconds, or you can hold it more. It's not too easy to do, though, I'll tell you. If you want to add weight to this, your weight should be above the knee. You see with the red line there, this is where the weight should be. A lot of people will put weight on the ankle, but the knee is between the ankle and the hip. And you want to get weight as close to the joint that you're working with as you can. And so this exercise is for the hip. So we want to have the weight above, or it's also called proximal to, the knee. When you lower the leg, lower it slowly, and that will give you an eccentric or lengthening contraction of the same muscle. So you get the muscle when you're going up, and you also get the muscle when you're coming down, if you come down slowly. And if you have a balance issue lying on your side, you can put your back up against a wall. Some contraindicated and cautionary movements that flex or bend. Flexion, you see, increases compression. This is of course, exaggerated a little bit. Side bending or rotating the spine, especially if you do all 3 altogether. And the big 3 activities to avoid with osteoporosis are tennis, golf, and bowling. Now, that's in the beginning. Now, I know that I work with a lot of people who are tennis players, golfers, and also bowlers. And so what I do is I say, well, what I'd like you to do is to just stop doing those activities while we get you on the program. And then if you still want to go play tennis or golf or whatever it is you want to do, see if you can get some coaching and get some good body alignment. And I can give you exercises that will help minimize your risk of an injury. But there can be a lot of injuries that can occur in all of these. So in physical therapy, we kind of recommend just avoiding these kinds of activities, especially in the beginning. It depends upon the patient again. Oh, this is almost my last slide. If a black cat crosses your path, be sure to pet it. These are my 4 black cats waiting for me to feed them tonight after this little webinar. Now, you see this guy, Jughead, and some of you may remember Archie and Jughead from the funnies. Jughead was the runt of the litter when I got him, and he and Archie are siblings, okay? And I'm going to show you a picture of what he looked like when we got him. This was when he was a baby kitty. I think he was the ugliest kitty I ever saw, and I immediately wanted him because I could tell by his eyes. You see his eyes? He's just like, oh, take me, take me. So I did. They were going to euthanize him because they didn't think that he would survive. I can tell you that now he is the biggest and heaviest cat. This is Jughead now. It's probably bigger than that picture is a couple of years old. And he just keeps growing, and he's just the most pleasant, wonderful cat that I can't tell you. He's just wonderful. So I'm so glad I saved him. Bobsy's a feral cat. I call her my funky feral feline, and she still acts like a feral cat. Okay, so that's about it. I'm going to be doing another webinar very soon on February 11th. It's at 10 a.m. in the morning until 12 noon. So you might want to put that on your calendar. It's called Practical Applications for Practice. It's really meant a little bit more for professional therapists, but I try to keep my language, and there's a lot of information for anybody who attends. Thank you very much for attending. And so Shelley, if you want to come in here and
Sure.
the questions, and
Sure,
I'm going to
absolutely.
stop.
That was fantastic. I want to thank you for starters before you even answer a question, because if that's all you did and no questions, it would be plenty.